Good afternoon, everybody, and welcome to our webinar. We are just letting people get in and then we'll start in a few minutes. Good afternoon, everybody. My name is Erica Defer-Malik, and I work at the Innovation and Value Initiative. We will be starting the protocol webinar in about 1 minute. Thank you, guys. Okay, I think we're going to go ahead and get started. My name is Erica Defer-Malik, and I am the Director of Membership and Patient Engagement at the Innovation and Value Initiative. I want to thank all of you for being here today on this busy time of year, and really are looking forward to your engagement and your feedback. This webinar is the IVI Major Depressive Disorder Model Draft Protocol webinar. This is an opportunity for you to learn a little bit more about the draft protocol, to learn about our process for requesting comments on our public comment period, and a chance to ask initial questions. We realize that the draft protocol just went out yesterday, and so we do want to understand that this is really an orientation rather than a detailed review. We will try to be as efficient as possible and make sure that we're as respectful for your time as possible. First of all, I want to acknowledge that we developed the protocol in partnership with Open Health. They have been a great partner in terms of helping us both develop the model scope as well as the draft protocol. And we are looking forward to having them partner with us in the future. Today's agenda, just want to give you an orientation about what we're going to be talking about today. We're going to be providing the objectives for our MDD model. We're going to be talking about the how we developed the model protocol. We're going to describe briefly our targeted literature review and outline the model structure and inputs. And then we will go into some detail about the key areas where we're looking for feedback. And then there will be an opportunity for questions and answers. We encourage you to also add comments and suggestions within the chat as throughout the conversation. And we will try to address those towards the end of the presentation. We are asking all of you to do 3 things for us, and we will really appreciate that. We hope that you will review and submit comments to us by January 18th. We hope that you will share the draft protocol with your colleagues in the field. And we hope that you will also share the recorded webinar with your colleagues if they also need some questions. We really take it seriously that we are a learning laboratory, and we are really looking forward to engaging in this conversation with you about how we can make sure that this is a meaningful and relevant economic model. We also wanted to take a moment to say thank you to our advisory group. We started when we first chose to focus on major depressive disorder before the pandemic. We really brought together a group of experts in the field. We included people with lived experience, clinicians, researchers, payers, employers, health economists, industry actors. We brought everybody together, and they really helped us conceptualize and inform how we were going to approach this economic model, because this as you look through the details of it, is not just a typical economic model. And so we really want to say thank you to those people that have really kind of come along this journey with us throughout and are looking forward to their feedback as we move forward. So thank you. You can learn more about who the people are. There's 20 different individuals at the link at the bottom of the slide. And now I want to pass it over to our speakers today. We have 3 speakers who are going to provide you with some of our insights about the protocol. We have Dr. Rick Chapman, who is IVI's Chief Science Officer. We have Mr. Danish Mir, who is the Director of Real World Evidence at Open Health. And we have Dr. Richard Z., who's our HEOR Research Manager at IVI. And now I want to pass it over to you, Rick. Thank you, guys.
Thank you, Erica. And I want to add my thanks to the advisory group for helping us to get this far. So I'm going to just provide a brief overview of the model and its objectives, and then I'll turn it over to Jordana to go into more detail on the structure and inputs. So if you could go to the next slide. Our objectives for the model are to build a flexible, open source, and patient-centric model. And we think that all of those are very important. We want it to be flexible so that it can serve multiple stakeholders, open source so that it can be transparent and people know what's going into the model and coming out of it, and patient-centric so that we reflect the most important stakeholder of all is the patients who are at the center of this. So our goals with the model are to advance the science and practice of health technology assessment in the US context, to facilitate conversations among stakeholders in this area, and to inform decision needs for multiple stakeholders, and that could include employers, payers, and clinicians. Next slide. So I'll talk a little bit about how we went into developing the draft model protocol on the next slide. Our open source value model, this is our 3rd open source value model. We have some in rheumatoid arthritis and non-small cell lung cancer. This one is, of course, for major depressive disorder. There's several reasons why we focused on major depressive disorder, partly the prevalence and the societal burden, and the broad interest from multiple stakeholder groups, especially as we went into COVID and saw the mental health demand spike and issues with access for a lot of people. Our model development to this point has been a team effort and will continue to be so. As Erica mentioned, we have a 20-member advisory group that has contributed to the model design and continues to provide insights. They provide insights for patient preference research that can be used as inputs in the model, as well as some of the decision context that will be uses for the outputs of the model, and have been allies for us through our public comment periods and use cases. And we're hoping now to open this up and get further comment and input on what should go into the model and what are the use cases or decision context in which the model would be useful to people. And so that's really where we're looking for your feedback now. If we could go to the next slide. So the MDD model will actually have separate modules. For example, there will be a module for multi-criteria decision analysis. But what we're talking about today is the health economic model. And really what we're hoping to answer with the model are a lot of research questions. As I mentioned before, we want this to be flexible, but there are specific questions that we've prioritized through discussions with our advisory group. And some of those questions are, what's the societal burden of untreated or undertreated MDD? I mentioned before access issues. So if people are having trouble getting diagnosed or getting to treatments, what's the burden that causes? How do key model outcomes vary for certain subgroups that may be of interest to specific stakeholders? And how does that differ from what we see for the overall population? So we want to look not just at the average patient, but also be able to look at important subgroups here. And then another question that's been identified as of interest to stakeholders is, can we identify low value care in existing real world treatment pathways so that we can steer patients towards more efficient care? Next slide, please. So we didn't go straight into the draft protocol. Many of you probably participated in our public comments on a draft model scope. We released that for public comment this fall, and then took the comments that we received from the public along with going back to our advisory group for some input on some of the comments, and finalized our model scope. And we used the model scope along with a targeted literature review, which Jordana will discuss in more detail, and took the results from that targeted literature review and our model scope to develop this draft model protocol. And once we get the public comments back in mid-January, we will be revising the draft model protocol and releasing a public version of the final model protocol before going to model development. Next slide. So I wanted to give just a quick overview of the scope of the model. This is what was the result of people's comments on the draft scope and our finalized model scope. So you can see the target population will be treatment-naive adults, age 18 to 64, who have been diagnosed with MDD by a healthcare provider. Now we're starting out with a population that's treatment-naive, but as you can see below in the time horizon, we will be following those patients for a lifetime. So some of those patients will go on to later lines of treatment and can also be examined within the model. We'll be looking at all settings of care, primary, specialty, and telehealth to the extent that we can find evidence on it in the United States. Our base case for the model will be a societal perspective and trying to include as many societal costs and benefits as we can. But as I mentioned before, the model will be flexible and allow different stakeholders to customize the output to what they're looking for. The structure of the model itself will be an individual level micro simulation to allow for that flexibility. And there will be flexibility to model treatment sequences or individual treatments, and we'll be including both pharmacologic and non-pharmacologic treatments. And if you want to see which specific comparators we're considering to include, you can look at the scope or the model protocol. As I mentioned, we'll be using a lifetime horizon for the model, but there will, of course, be flexibility for users to stop the model at earlier time points. The outputs will also be flexible. We want to be able to provide different outputs that will be relevant to different stakeholders, and so that will be built into the model. And as part of that, some of the key considerations that came up in our discussions with advisory groups or from comments on the model scope were that we should be sure to include considerations around productivity, adherence to treatments, and the impact of delay in starting active treatments for MDD. So will be some of the things we look at. And I just want to mention here, I've talked a lot about flexibility, and that really fits in with our philosophy with this model. We don't want the model to be just a model that looks at one treatment versus another. We really want it to be able to look at multiple treatments, but even beyond that, we want it to be useful as a test bed for different methods or techniques that we might want to try out in economic modeling, really trying to advance the methods for the field as well as provide an important tool for those who are interested in MDD. And if you go to the next slide. So now I'll turn it over to Jordana from Open Health to go through a targeted lit review. I did just want to mention, we had a couple of questions here that I see in the chat. One for how we define treatment naive. That's really just patients who have been diagnosed but who have not yet received active treatment from a healthcare provider. And then for examples of outputs for the model, some of that we will be providing costs, life years, quality adjusted life years, but beyond that, we'll also be looking at more specific outcomes, how many hospitalizations do patients have, resource use, and that sort of thing. We're exploring the ability to look at suicide and suicide attempts, but that's an area where we're finding a dearth of data, as I believe Jordana will mention as she goes through her exposition of the model. So now I'll turn it over to Jordana and let her explain more of the details.
Okay, thank you, Rick. So before we get too far, I feel like I'm going to be introducing, asking a number of questions and posing a number of points to the group and participants today where we don't have information. But I do want to point out that it was only a few slides ago where Rick was able to share a lot of information on decisions that, with the assistance from the advisory group and from other stakeholders and from IVI, that there has been a lot of progress in in identifying the scope of the model. And some of these things, thankfully, are much more straightforward than some of the challenges that we are posing to you today and in the next month or so. So, and one of the reasons that we're talking today is because the model type that's been being proposed, the microstimulation that Rick mentioned, has really tremendous data needs. When we're following patients, individuals with MDD over many years through many treatment sequences and through the ups and downs, that's the real world experience of major depressive disorder. There's a lot that goes on in the life of a patient, and the family, and the, which is also part of, which also plays into the model. We want to get it right, but we also don't want, as I think Erica also mentioned, don't want to be limited, and don't want to be, we want to be able to be creative and think ahead. And so that's the reason for some of the challenges that we are sharing with you today. Can we go to the next slide? Okay. So in thinking about how to populate the model, once we had designed the scope and shared it several months ago, our initial plan was to identify meta-analyses that would help fill some of the gaps and populate some of these inputs that would be needed. We expected that for many of the inputs that we were interested in, we would be able to find meta-analyses that would allow us to populate the model without having to make our own judgment calls about what is the best study to include in one place or another. It also would allow us to ensure that no single study would dominate the inputs. And given that most of the treatments that we are interested in, of course, many of them have been out for a long time, we thought that there would be data available. And as many people on the line are probably familiar with, going to meta-analyses is a reasonable starting point for identifying inputs for models like this. So we focused our search only on papers in English. And we made one decision with the team from IVI fairly early, which was that since there is an interest in following people for a long time, and since treatment-resistant depression is often defined as depression that isn't adequately that persists after 2 adequate courses of therapy of the appropriate dose and duration. We also looked specifically at studies on treatment-resistant depression with an eye towards using those data to populate 3rd and 4th line therapy in the model. I think from the discussions with the advisory group early on too, that was something that that everyone was comfortable with, that we have consensus on that. So the protocol contains more detailed information about our search. But once we conducted a full text review of the eligible reports with the understanding that there was a budget and a timeline and only so much that could get done in a certain period of time, we actually only found 16 studies that met all our criteria. And they all reported effectiveness. Safety was reported here and there, and costs and utilities we really didn't see in the meta-analyses. And because when you look at the number from 455 and then you say, well, how did 16 happen? we found a number of meta-analyses that would report that they included only adults without other psychiatric conditions, which is one of our limitations for this initial implementation of the model. And then by the time we get to supplementary tables, we're looking at, a few studies included patients with schizophrenia, and a few others had patients with bipolar, and there were some teenagers in another study. So once we started getting down to that level of detail and reviewing the supplementary tables, it became more difficult to keep up the numbers in the meta-analysis. Process was definitely not as smooth as we had, I think, all anticipated. Can we go to the next slide? So there were some inputs that we didn't expect to find reported in the meta-analyses in the beginning, and we've sought out a number of data sources already. For example, we didn't expect that mortality would be reported in meta-analyses, which were typically, no surprise, focused on clinical trial data or shorter term observational studies. So we do have sources that we detail in the protocol that we can use for all-cause mortality and for depression-focused mortality, and studies that include treatment-resistant depression-related mortality to use for third and fourth line therapy. For costs, which I'll talk about a little bit later, there's many sources that we can turn to develop the estimate for costs to apply to different health states. And I had already mentioned that while, meta-analyses are the not only the subset that we looked at, but even others are likely not following people through fourth line therapies, but using results from treatment-resistant depression studies will help populate that. We really didn't anticipate the number of challenges with finding data on effectiveness or safety or utilities. And I'll go into each of those a little bit more later. I know in general, we say, there's plenty of safety data, but it's not necessarily as easily translatable to populating the model. Can we go to the next slide? Okay, so now I'd like to tell you a little bit more about some of the details. First, about the structure of the model, and then what kinds of inputs we need to populate it. So as I mentioned, and as Rick mentioned, the approach that's been favored is a microstimulation, which has been used in the previous models that IVI has sponsored, and has been used in some other models for major depressive disorder. It can do a really good job at reflecting heterogeneity in the population, which is something that we know is an issue and that we'd really like to be able to explore. There are some pros and cons of the approach, of course. It's very forward thinking and it allows us to customize insights, inputs, like it's very flexible. However, we do need to constrain the number of health states just because there are computational challenges that will emerge, and that since one of the goals is for this model to be usable and understandable by a wide variety of people and stakeholders who may not be comfortable with programming it themselves, it has to be manageable. And the other big challenge, and that's one of our topics here, is that there really aren't a lot of data available on some of the really neat things that we'd like to be able to do with the model. So we are already almost, as you will read through the protocol, you will notice that there's a lot of placeholders for the future that we hope studies will help provide insight there. Okay, on the next slide, I'd like to show you what the model will look like. So individuals will enter the model with a diagnosis of depression, and they can either initiate treatment or they can decide not to. So the model assumes that individuals who do present for diagnosis but don't receive treatment will go into that no response health state. The health states that are represented here are generally consistent with what we've seen in published models and consistent with how clinical studies typically evaluate response. So they're distinct in many of the outcomes that we've identified as meaningful for the model. The challenge is each of these letters represents a probability that would need to be assigned in order to understand the probability of transitioning from one health state to another. You'll notice there are some loops where someone would stay in the same health state. Everything except for death has the ability to leave that health state for obvious reasons. Let's see. So some of these transitions the transitions would be different for each intervention, and they may be different by some of the socio-demographic and economic characteristics that we are interested in considering in the model. And they may actually, we may want them to differ based on the number of treatments that an individual has utilized so far. So there are a tremendous number of transition probabilities that we will need to decide upon or make assumptions about in order to operationalize the model. So can we go to the next one? Okay. So both to simplify and to acknowledge the paucity of data, these health states sometimes serve sort of double duty. We've made some suggestions and recommendations here, but these are definitely some of the issues that we would like to, for which we would like to receive input. So for example, we are recommending that an individual who remains in the complete response health state for multiple cycles be considered to have achieved remission. This seems consistent with literature, but whether we talk about whether that's 2 or 3 cycles, that's certainly something that we should be discussing. The benefits and outcomes associated with complete response or remission would likely be fairly similar, so that's a reason to have double duty for that cycle. Exactly how many cycles until you hit complete remission could vary if we think that the definition could change. We're also suggesting that a reduced response, where someone had a complete response and then transitions to partial or none, could reflect a relapse or a recurrence. But again, the question of exactly how many cycles of complete response, how much time in complete response would one need to spend before we determine that it's a relapse or a remission is both the default, and do we want some options available for the user? And that needs to be decided. And those decisions are particularly important because some of the outcomes that we would like to include are not just number of hospitalizations and resource use, but how much time in remission. And how you define remission, of course, is essential to figuring that out. We can say how many cycles in complete response, but if someone spends 1 cycle in response and then for some reason drops out, that's a very different experience than maintaining that cycle for a longer time. Because so many clinical studies don't follow individuals for very long, these decisions will need to integrate both clinical decision-making and guidelines, but also have awareness of what the real world experience is. Let's see. So we have some proposed questions that we've shown, but I think there's more details in the protocol, and we can discuss a little more later too. Can we move to the next? So most of the models that we reviewed were limited to a few years of follow-up. We identified some models that explored time to augmentation or time to a switch, but there's really nothing that attempted this type of long-term follow-up. So none of the documents that we reviewed really had to make some of the decisions that we're asking to make here. The challenge is really that it would be one thing to follow guidelines, and it would be another thing to think about what trials might look like. But the balance between those is the balance between the real world experience and maybe best practices and following guidelines is we need to find some space in between there. And we did to Rick's comment about whether there is to think about under treatment, the idea of maybe we have scenarios where there is more of a passive approach to care and maybe sort of lower quality care and maybe not as well funded, and another with a more aggressive plan, which might mean that patients are more likely to switch sooner if they are in a partial response state. So there are all kinds of ways where those questions can be addressed by modifying some of the decisions that we make about these transitions. Next slide, please. Okay. So to be clear, we have made some simplifying assumptions in the health states already, and that we recognize that there are a wide variety of measures that are used to evaluate and define response. They're not always used consistently across studies, but for the most part, they're fairly close. Whether exactly what the cutoff might be on the Hamilton depression rating scale is, we believe, not as essential to whether we're willing to call that a response or not. And consistent with what we found in meta-analyses, a lot of the authors there were willing to say, oh, the threshold might be different by a point or two, but that's okay. Again, our challenge is really how do we figure out how to move individuals from one health state to another one with limited data available to us, and a longer follow-up than in the vast majority of studies in this space. Okay, can we move to the next slide? So as Erica mentioned, this is not your basic run-of-the-mill cost effectiveness model. If we were doing that, we'd likely be comparing one treatment to another, or maybe a second treatment for those who failed or didn't have an adequate response to the first treatment. Because those studies typically compare a novel treatment with an existing one, they're not a lot of head-to-head studies to choose from to select for effectiveness inputs. But because of the comprehensive nature of this model, we're left with a much broader universe of possible inputs. And the approaches to finding those inputs are either, broadening the meta-analysis and the review search that we initially conducted, conduct our own meta-analysis, or turn to individual studies. Even with that, there's a potentially huge gap between what we know, even from the longest term studies, to what the model's ultimate goal is. In terms of costs, we have two possible options. We can use findings from available studies on total healthcare costs for individuals with major depressive disorder and determine the proportion of costs that are attributable to depression. The other approach is to start with guidelines and build a bottom-up estimate for the cost of depression. And for that, we might even consider a more sort of active, perhaps higher care, higher quality care, maybe better funded care approach, and have alternatives to that. This is a place where I'm glad to say there are data available for us. There are just multiple approaches, and with the collaborative spirit that I think IVI has tried to infuse throughout this, are sort of open to, is there a preference for one approach or the other? In addition, my understanding is that the IVI team is helping to support some additional work that might help with some of this resource use, with the resource use inputs. That said, there may also be other studies that other stakeholders are involved in, and if you would be willing to share anything with IVI or with us about that, that would be fantastic too. Okay, on the next slide, we have a few other areas that we're looking for insight on. So treatment sequencing is one of the novel and I think pretty exciting elements to be included in the model. However, as you know, there are not a lot of studies that combine like insight from about individuals with depression and clinicians and actual treatment patterns that can really help inform what happens in the real world. Like how does switching really happen? Um, uh, with limited information on bothersome but not costly and not serious adverse events, figuring out exactly when these switches should happen is not an easy task. We can make some assumptions, and we could say that 95% of individuals who have a complete response to treatment will continue with that treatment. And I think that's a reasonable starting point. But when individuals, as we know in the real world from many studies, I'm thinking about the patient experience, patients may be willing to remain in a partial but incomplete response state because there's a particular adverse event that they are trying to avoid. So keeping things like that in mind and not forcing people to move to make transitions based only on response is an important thing to consider also. And in trials, patients may be encouraged to stay on treatment a little longer than they might in the real world. But a lot of those studies are the ones that are contributing to the meta-analyses. So again, we have a little bit of a chicken and egg problem. But ultimately, we do want most of the model inputs to be modifiable by the user. The question is, what's the default, and what's the range around that, and does that link to any other inputs such that we need to think about them as a unit? So another challenge is safety, which again, we all think, oh, well, we know there are adverse events, but there are sort of a couple buckets of adverse events. There are burdensome adverse events that don't have much of an impact on adherence, that they don't have a cost associated with them. People aren't going to discontinue because of them, and they really don't affect utility values, utility estimates from patients very much. Those are important. And we might want to be able to count them, but they don't interact with as many other components of this model. It's easy enough for a number of adverse events like tardive dyskinesia. Like we can attach a cost to treating these things, and for some of them, there are estimates of disutility, which is a decrement in utility value. There are a few that we propose in the protocol that we think would be hard to ignore, but we do want your input also on whether there are other adverse events that maybe are relevant for some treatments, but so important for those that they need to be included, even if they aren't consistently found across multiple treatments. The other challenge is how to think about suicide in the model. I don't think there's disagreement that it's important at all, but we do have to think about how to separate out suicide that might be more symptomatic versus related to an adverse event and increased suicidal ideation, and whether we really have sort of two buckets for how we count and attribute suicides in the model. The last thing, and I know that this is a difficult concept in a lot of ways, not difficult, but somewhat controversial sometimes in depressive disorder. But we did want to include utilities as one of the inputs in the model. However, there is a really broad range of values for what we believe are pretty similarly described health states. So we've included those in a few options in the protocol, But again, our understanding is that there may be some ongoing studies, or that there may be insights from that others can bring. There's also nothing that we found yet specific to utilities or disutility and challenges associated with some of the somatic therapies that we're talking about, including many of which were not included at all in the studies from which the utility values in the protocol were derived. So we have some possibilities there and some options, but insights on whether one set or another is more appropriate, or whether perhaps none of them are, would be great. Yes, and utility, I see Rick's comment. Yeah, so for anyone who's not familiar with the idea that patients can value their time and the quality of their time on it, there's a scale from 0 to 1, with higher values meaning better utility. 0 is supposed to be similar. It's supposed to represent death, but again, in major depressive disorder, there are actually a few studies that suggest that people with severe symptoms of MDD might actually value that health state as worse than death, which is another complication that perhaps we should not get into today. Okay, and then I will hand it back, because now I see conversations about comments from things that I don't have the answers to, but we very much appreciate your input and insight into some of these challenging areas for the model. We understand that the model itself, for people who may not be familiar with modeling in general, like there's a lot to go through, and we hope that there's much more information in the protocol that will guide you through some of this. But again, I'm sure everyone will be happy to address questions that come up. Okay. I will.
Thank you so much, Jordana, for that deeper dive into the technical specification of the model protocol. And I hope that gives you a flavor of what we're proposing and some of the challenges we are trying to address in this public comment period. Next slide, please. So during this public comment period, there are really 3 specific areas that we're trying to get feedback on. And as you kind of get a flavors of them, the first one is the data gaps in key model assumptions and inputs, as well as potential data sources or partners that we can work with to identify these inputs. For example, caregiver burden or suicide attempts. The second is prioritization of data sources or technical approaches when there are multiple ones that exist. An example, again, here's utility inputs. We have identified 4 or 5 studies for which we might be able to populate with. So which one of them should be prioritized, or should they even be prioritized? The third one is, really the potential use cases or the applications of the model, especially after you have taken a look at it. One is for your organization, in what ways do you think this can be useful? We had a question about output, what kind of output should be generated to support that decision context. Secondly, if you, in your conversation with some of the end users of the model, such as payers and employers, if you see that there's a gap, and if there's a way in which the IDI model could be helpful, we also welcome those feedback. Next slide, please. So at the top of the protocol, one thing you will see is that we have a consolidated list of questions, and these questions can broadly be, divided into 2 categories. One is the more general methodological questions, such as, how do we derive efficacy inputs for 3rd or 4th line treatments in our model? It could be an assumption, it could be a data sources, it could be a method to extrapolate. Second is, second type is more specific questions, such as Jordana mentioned, for example, the suicide attempts. What are some of the good data sources we can use to populate and model that specific event? Next slide, please. And also to really to encourage your input and get this conversation going on potential use cases or applications. So we also wanted to provide you with some examples. And here by use cases, we really are thinking about some of the novel research questions or some of the decision contexts in which the model can generate useful insights on. So some of these examples here include the following. What is the impact of the delay in diagnoses? What's the impact of that on the long-term economic and clinical outcomes for the patients? The second one is, we do intend to incorporate a Medicaid perspective down the road. So what is the impact of effective MDD treatment strategy on the ability for Medicaid to ensure individuals to regain employment and potentially transition out of Medicaid and into private insurance? What is the impact, in terms of the well-being of the individual and also from societal perspective, the productivity gain and such? The third one is coming more from the employer perspective. So one of the things in our conversations with employers that they are trying to work on is, to sponsor or identify programs that can improve the employees' adherence to chronic medications. So when you have a choice of different programs, what is the impact of improved adherence on productivity and other outcomes? And can we model more patient-defined factors that might affect adherence to therapy? Lastly, and this is one area, as many of you might know, is in our ongoing collaboration with the PACE Center, the researchers at the University of Maryland. One thing we're trying to understand is patients' preferences for the different treatment attributes for MDD. And for that, one question that comes out of it is, to what extent can we incorporate that in the context of economic modeling? What is the long-term value if we're to consider the heterogeneous patient preferences for treatment, and if we're tailoring treatments based on patients' preferences? And what is the impact of that on improved likelihood of good or improved economic or clinical outcomes? Next slide, please. So yes, with that said, again, to reiterate what Erica has said before, I'll ask of you for this public comment period for the model protocol is please review and share your comments by January 18th, 2022. Please share with your colleagues, and please also share this recorded webinar with your colleagues. And there are two ways you can provide comments here, either through submit a document via email to public.comment@thevalueinitiative.org or respond to the survey. These links are also available on our website and also in the draft model protocol document. Next slide, please. And here we also, so Rick gives you a sense of like the next steps and timeline for the protocol finalization period. And also on a project level, here's what we're envisioning for the timeline and the next steps for the overall project. First is we're expecting to finalize the model protocol by February, end of February 2022, based on your feedback and also some additional targeted outreach, and also in consultation with the advisors from the MDD advisory group. And then we're aiming to release the prototype of the model by end of second quarter next year. Of course, during this process, we also are continuing conversations with different stakeholders on developing, applications or use cases, and also incremental updates to the model that would make it more relevant to the decision context of different stakeholders. Next slide, please. So with that said, this is actually the presentation of our webinar today, and now we welcome your questions. And now I'm going to also invite Rick and Jordana to come on camera as well.
Thanks, Richard. Jordana, I don't know if you saw, but there are a couple of questions in the Q&A. I'm hesitant to read those because they're pretty detailed, but one was around, I think there's parts in the protocol where we talk about dose adjustments after 4 to 8 weeks, but then we talk about another point, we talk about 8 to 12 weeks, and then we're using a 3-month cycle length for the model. So just wondered if you could talk a little bit about that discrepancy.
So one of the things that we had talked about, including in the model, is the ability to have augment sort of to consistent with guidelines to allow someone to go back to the provider at 4 weeks, 6 weeks and say, well, I'm not really sure. But then to be able to have a change in dosage or perhaps some sort of augmentation that would not actually be recorded in the model as a treatment switch, that they'd still stay primarily on that same line of therapy. And so so that gives us the option. There's some discussion early on in the model development process about whether a cycle should be shorter than and I think that that would not reflect the fact that most people, I think, would go back and not have. If we advance them to the second line of therapy after 4 weeks, this model is going to not be as useful, I think, as it can be if we sort of follow the real world patterns and say, well, they're going to be asked to try a little longer. If the model cycle is something that we need to bring back to discussion, it's more transition probabilities to think about. So just keeping that in everyone's mind too. I don't know if that helps. Provides a little clarity around that.
Yeah, I think that gives some background into our thinking around that. And it is one of those areas where you always want more granularity in models, but you realize that the trade-off is greater evidence needs and computational issues, as you mentioned before. It exponentially increases the amount of information and computing power you need.
Yeah. I absolutely agree. I think it's really a triangulation of the evidence base and also our conversation with our clinical advisors and also the guidelines is really trying to come up with that delicate balance, and that's why 3 months was proposed here. But we definitely welcome feedback if you have any approaches we can consider there.
Yeah.
So another question I want to flag is actually discontinuation. So one thing we did not explicitly specify in the protocol is do we consider patients discontinuation and then reinitiation of the therapies if there's a gap in treatment? So Jordana, do you want to shed some light on that and also share some of the highlights from our ongoing conversation?
Yeah, so the question, I think there's every expectation that someone could discontinue or initially even decide not to be in treatment and then decide that they would like to be receive one of the many treatments that are an option. The question about whether to some extent forcing someone to stay in a no treatment space allows us to look at that question of under treatment, but we would expect to have values, as you could see in the model structure, where someone could go from that no treatment cycle, no treatment or no response space, and move into another health state, because unless there's a reason to think there would be spontaneous recovery, which would be great, but we're assuming that there would be that they would at some point decide to, or could at some point decide to move into treatment and then have the opportunity to cycle through and have a response or not, if the case may be. So they're not forced to stay in the no treatment bucket. It's just a question of when they move to someplace else.
And I wanted to also add a little bit to what Jordana said. Yes, the discontinuation rules is something that's on my mind, on our minds, but probably hasn't been completely specified. We haven't probably could specify all the scenarios in which discontinuation could happen. One thing structurally this model is equipped to do is, because no treatment is going to be a treatment option in the comparators and treatment strategy. So that will allow us to model that. And again, you know, and yes, like another question from Robin is, I guess one thing you're asking is, can they also stop treatment if they were in other health states? And I think that's a possible yes, depending on the scenario specification. Yeah.
Yeah, and I'll mention, along with discontinuation, another thing we've been struggling with is how to handle adherence in the model. You know, as most of you probably know, there's not always a lot of great information out there on adherence, and more especially how adherence may impact effectiveness. And especially where we're thinking that's going to be lacking is in the non-pharmacologic treatments. And so if anybody has any insights into how we might deal with some of those issues, we'd really appreciate that feedback.
And one last thing I want to add to the discontinuation dialogue is another safety outcome that we are trying to, you know, distill or sift through is also discontinuation due to AE. And that could also be a channel through which discontinuation can happen. So again, if you have any insights or suggested approaches, we'll welcome those inputs. And I see one more question here. This is a question about, will the efforts with paid project regarding patient-reported outcomes be incorporated into utility measures for this version of the health economic module? And so that's actually something we're actively working with our collaborators from the PACE Center on. And we do envision a few ways through which we might be able to augment or adjust utility measures based on additional value elements identified by patients. Second potential way we can do that is we're trying to understand the preference heterogeneity of different patient subgroups, and that might give us a way to model how the differential utility values or inputs or quality of life impacts for different patient subgroups. So that is also something we are exploring. And currently we're still fielding the survey with that study, but we're definitely looking forward to work with our collaborators from PACE Center to specifically define how we're going to do that. And hopefully we can incorporate that in the finalized model protocol to provide more specifics to the readers.
Okay, I think we had one other question about whether we're going to consider a waning effect over the time horizon. And Jen, did I see that you wanted to respond to that? Maybe not. You know, I think as Jordana mentioned, the long-term extrapolation of treatment effects is one of the things that we're really struggling to find evidence on. Most of the studies are relatively short term. And so we will be continuing to look for that information and consulting with clinicians. But again, that is something we would love to hear from other folks over what they think should be done in those situations, what they think reasonable assumptions around effectiveness over the long term would be. And we're getting close to time. We might have time for one more question.
One last question is, if we have data on particular groups with comorbidities, could we, you know, run the model for that patient population if the model is released? Okay, so maybe I can quickly, you know, share some of our thoughts here, and Jordana and Rick, please chime in. So this model, in this version, we are not explicitly modeling the impact of MDD treatments on other comorbidities. But one thing you can definitely do is to populate the key metrics or the input for the particular subgroups in our model, and they should generate insights, you know, for the subgroup with those comorbidities, at least for the main outcomes or the treatments related to MDD. And the other thing we are looking to explore in the later versions of the model is to perhaps explicitly model how the treatments of MDD might be able to impact the outcomes of other comorbidities.
Yeah, we may not be able to, completely populate a lot of these types of analyses in the first version of the model, but we do want to allow the flexibility for placeholder inputs so that people have their own data or want to make their own assumptions. They can put those into the model and see what the results would be. So I think it looks like we're at the hour. I want to thank everybody for attending and for your questions. And thank you in advance for your feedback on the draft protocol. Again, the deadline for comments is January 18th. We'll be accepting comments either via email or by survey. And the links to both of those are available on our website where we discuss the MDD draft protocol. Thank you all.
Thank you, everyone.